Hello, my name is Ariana Palma and I'm going to talk about procedural volume and outcome for transcatheter aortic-valve replacement. Definition. What is a TAVR? This minimally invasive surgery procedure repairs the valve without removing the old, damaged valve. Instead, it waves a replacement valve into the aortic valve replace. The surgery may be called Transcatheter Aortic-Valve Replace, TAVR.
This is an animation showing transcatheter aortic valve replacement through the transfemoral approach using the Edwards SAPIEN 3 transcatheter heart valve. The heart's main function is to pump blood to the rest of your body. The heart contains 4 valves. Normal valves have 2 or 3 flaps of tissue called leaflets that open and close like gates to control the flow of blood through your heart. It's important to know that if you have aortic stenosis, your aortic valve narrows due to calcium buildup. This prevents the valve from fully opening, which blocks blood flow from your heart to the rest of the body. As a result of the reduced blood flow, the body does not get the oxygen it needs, which can lead to symptoms. Aortic stenosis is a progressive disease, which means it gets worse over time. It's typically measured as mild, moderate, or severe. The only effective treatment for severe aortic stenosis is to have your aortic valve replaced. Today, there are 2 options for replacement: open heart surgery or less invasive transcatheter aortic valve replacement, also known as TAVR. During the TAVR procedure, you may be placed under anesthesia. Once under anesthesia, a small incision will be made in your leg, where your doctor will insert a short hollow tube called a sheath into your femoral artery. Sometimes, as a first step during the TAVR procedure, balloon aortic valvuloplasty, also known as BAV, is performed in order to open your narrowed calcified valve. Once the sheath is in place, your doctor will guide a catheter with the balloon on the end of it up to your aortic valve. Once the balloon catheter reaches your aortic valve, the balloon is inflated to open your narrowed calcified valve. The balloon catheter is then deflated and pulled back from the aortic valve. During the next step, your new transcatheter heart valve is crimped onto a delivery catheter, which makes the valve small enough to fit through a sheath, so it can be delivered to your heart. Using a special type of X-ray, your doctor will guide the delivery catheter carrying the new valve through the sheath and up to your aortic valve. The balloon of the delivery catheter is inflated with fluid, expanding the new valve within your diseased valve, pushing the old leaflets aside. The balloon is then deflated and the delivery catheter is removed, leaving your new heart valve in place.
Application. How does it work? Somewhat similar to a stent placed in an artery, the TAVR approach delivers a fully collapsible replacement valve to the valve site through a catheter. Once the new valve is explained, it pushes the old valve leaflets out of the way, and the tissue into replacement valve takes over the job for regulating blood flow.
The frame of the Edwards SAPIEN 3 transcatheter heart valve is strong and will use the calcified leaflets of your diseased valve to secure it in place. Once in place, the SAPIEN 3 valve begins functioning immediately, with the leaflets opening and closing to pump blood to the rest of your body. The most serious risks of the TAVR procedure are death, major stroke, major vascular complications, and life-threatening bleeding. If you or someone you know has severe aortic stenosis, only a TAVR heart team can determine which treatment option is best for you. Ask your doctor to refer you for a TAVR evaluation. To find a specialized heart team at a TAVR center near you, Visit newheartvalve.com.
Pros and cons.
The aorta.
Procedural complications for TAVR include risk of stroke and vascular complications. But for patients unable to have open heart surgery, TAVR effectively lowers overall mortality rates among these high-risk patients.
The stroke rate is a little higher, but again, we're talking about inoperable patients who otherwise would not have a choice of life. And so the stroke rate, while it's a little bit higher, still we feel is acceptable.
Pro. This procedure is fairly new and is FDA approved for people with symptomatic aortic stenosis who are considered an intermediate or high risk patient for standard valve replacement surgery. Usually, valve replacement requires an open heart procedure with a sternotomy, in which the chest is surgically separated open for the procedure. The TAVR or TAV procedures can be done through very small openings that leave all the chest bones in place. Cons. Complications involve the aortic dissection or perforation, aortic valve complex injury or rupture, or left ventricle perforation have become very rare but potentially catastrophic. In terms of durability of the implanted prosthesis, valve position, the morphology of the prosthetics leaflet, and indices of valve stenosis and regulation should be evaluated with electrocardiography. Issue applied in Ecuador. The head of clinical area cardiologic unit and head of area of surgery of the cardiothoracic unit performed the valve replacement since 2015, where they implement a new producer, the transcatheter valve implant aortic stenosis for aortic stenosis. The device used for the transcatheter aortic valve implant is the core valve of Medtronic with diameters of 26, 29, and 31 millimeters according to the size of the aortic ring.
In patients with severe symptomatic aortic stenosis, transcatheter aortic valve replacement, or TAVR, has become the preferred therapy for those at high surgical risk. However, the efficacy of TAVR in patients at lower surgical risk has been less well studied. The surgical replacement and transcatheter aortic valve implantation study was a multinational, non-inferiority trial that enrolled patients with severe symptomatic aortic stenosis at intermediate risk for surgery, defined as a predicted 30-day operative mortality between 3 and 15%. The patients were a mean of 79.8 years old, and many had hypertension, diabetes, chronic lung disease, and frailty. 1,660 patients were included in a modified intention-to-treat analysis and were randomized either to TAVR with a self-expanding bioprosthetic valve or to surgical aortic valve replacement. The incidence of the primary endpoint, all-cause mortality or disabling stroke at 24 months, was 12.6% in the TAVR group and 14.0% in the surgery group, indicating that TAVR was non-inferior to surgery. Patients in the TAVR group had higher rates of residual aortic regurgitation and need for pacemaker implantation, while patients in the surgery group had more acute kidney injury, atrial fibrillation, and transfusion requirements. Patients in both groups had significant improvement in their quality of life scores and New York Heart Association symptoms, but the TAVR group improved more rapidly. The authors conclude that TAVR is a safe and effective alternative to surgery in patients with severe aortic stenosis who are at intermediate surgical risk.
Conclusion. In my opinion, at this time, the procedure is reserved for those people for whom an open heart procedure poses intermediate risk. For that reason, most people who have this procedure are in their 70s or 80s and often have other medical conditions that make them better candidates for that type of surgery. TAVR can be an effective option and improve quality of life in patients who, oversight, have limited choice for repairs of their aortic valve.